Good evening and welcome to Doctors on Call. I'm Dr. Ray Christensen from the Department of Family Medicine and Community Health at the University of Minnesota Medical School, Duluth, and I will be your host for tonight's program on upper GI problems. We would be glad to take your questions on indigestion, heartburn, ulcers, gallstones, and other abdominal problems. The success of this program is very dependent upon you, the viewer. Please call in with your questions and we will do our best to address them. The telephone numbers for your questions can be found at the bottom of your screen. Our panelists this evening include Dr. Brad Irwin, a gastroenterologist with St. Luke's Gastroenterology Associates, Dr. Dan McKee, a gastroenterologist with Northland Gastroenterologist, and Dr. Paul Sanford, internal medicine specialist with St. Luke's Internal Medicine Associates. Our medical students answering the phone tonight are Travis Mervichka of Glencoe, Minnesota, Samu Miller of New Ulm, Minnesota, and Marie Whippler of Parker's Prairie, Minnesota. And now on to tonight's program on upper GI problems. Dr. Sanford, could you tell us what indigestion and heartburn are? Let's start on the upper end of the GI system this time.
Oh, good. We'll start at the front door. Well, indigestion or heartburn is where you've got an uncomfortable sensation, usually in the food pipe or esophagus, and can happen from acid washing up from the stomach into the food pipe, or it can happen from some type of irritation in the food pipe itself, ulcerations, yeast, viruses, anything like that.
Dr. Irwin, that leads us to think, as we talk about things washing up, possibility of discussing reflux just a little bit.
Right, so reflux esophagitis, as Dr. Sanford mentioned, acid can reflux into the esophagus, as can bile and other alkaline substances, and that can lead to damage to the lining of the esophagus, and that's sort of typically what we refer to as reflux esophagitis.
Another topic that's, Dr. McKee, that's been tossed around a lot lately, and we chatted about it a little bit before you came. Back when I started practice, I don't think we knew much about it, but Barrett's esophagitis. Do you want to tell us a little bit about that?
Sure. Barrett's is a change in the lining of the esophagus. It's thought to be primarily due to long-term exposure to reflux. And we're concerned about Barrett's because it's a potentially precancerous condition. In other words, people who have Barrett's have an increased risk of potentially someday developing esophageal cancer. Most people who have Barrett's won't develop cancer of the esophagus, but they have a much greater risk of developing esophageal cancer than folks who don't have Barrett's. So if you have Barrett's, you need to periodically have upper endoscopies performed and biopsies taken to check to see if there's any evidence of progression towards cancer.
Dr. Sanford, are there things that we can do to avoid being in the situation where Barrett's would be a problem?
Well, things that can make reflux worse include chocolate, alcohol, caffeine, and if you eat a lot and then go to bed. Good rule is try not to eat or drink anything within 2 hours of going to bed at night, and if you're having reflux symptoms, go talk with one of these two guys.
Dr. Irwin, anything to add on that?
Yeah, no, I think we sometimes downplay the anti-reflux measures, and in actuality, a lot of folks will get started on over-the-counter antacids or get started on proton pump inhibitors like omeprazole, Prilosec, Nexium, etc., and think the problem's gone. In reality, those medicines, while very good at reducing acid, you oftentimes still have reflux. So not only may your symptoms continue, but the problems that Dr. McKee talked about with the development of Barrett's could still be progressing. So removing that reflux mechanism where things wash up into the esophagus is very important. So that's absolutely critical, in addition to making sure you don't have Barrett's. And
so if a person has reflux, is this a lifelong, is this something that, like diabetes, that you're going to have to treat for lifelong, or are there ways that you can make it better and maybe?
Right, so if the simple things don't work, like omitting caffeine, chocolate, peppermints, elevating the head of the bed at night and avoiding meals before you lay down, don't work, oftentimes we'll go ahead and proceed to endoscopy. Times we'll find things, predisposing conditions like hiatal hernias. Patients that have large hiatal hernias that are symptomatic, sometimes we'll proceed to surgery to repair that, and that could actually prevent their reflux and maybe even slow the progression of Barrett's or even turn that around for them.
Dr. McKee, can you tell us a little bit about endoscopy and what that is?
Well, endoscopy is a commonly done procedure where we take a lighted, flexible instrument and, under sedation, of course, go down the esophagus and get a look at the esophagus and stomach and the upper part of the small intestine. And then if there are any abnormalities, we can easily get biopsies or tissue samples for the pathologist to look at. We can also do therapeutic maneuvers if they're indicated. If there's, for example, active bleeding, there are techniques for stopping bleeding, and narrowings in the esophagus can be dilated. There's a whole really long list of therapeutic interventions that can be performed as well.
So as long as we're in that area, did you have something you were going to jump in with?
No,
I thought
I'm
you were
just
saying-
listening. Yeah.
So what can cause difficulty swallowing? What kind of things can do that?
Well, difficulty swallowing or dysphagia can be from a number of things. There can be narrowings or strictures in the esophagus, which can be from acid reflux causing scarring and or inflammation. Commonly, dysphagia is due to Schatzki's ring, which is an infolding in the lining of the esophagus. Fortunately, less common causes are tumors, either benign or malignant, but that's the thing we worry about the most. Sometimes there isn't actually a physical blockage, but trouble swallowing can be from an inflammatory process called eosinophilic esophagitis, which is an increasingly recognized problem. And then sometimes it's a problem of nerve or muscle dysfunction, where the muscles of the esophagus don't contract as they should, and so the esophagus doesn't function properly as a pump to propel food or liquids down into the stomach.
Paul, this is a really good question. How can you tell if chest pain is your esophagus?
Wow, it's almost like they share the same nerves as the heart, and it's often very hard to tell if something's angina or reflux esophagitis. The real trick is, does it get better with antacids? Does it get better if you burp? Do you have it only after eating? Nowadays it's worthwhile to have it checked out, stress test, and if the cardiac workup is negative, then take a peek at the esophagus, make sure there's not a stricture or something else.
So they really need to see their primary care doc and look at the cardiac side of this first.
Yeah, unfortunately, especially in women, cardiac ischemia, heart disease, can present as gastroesophageal or reflux symptoms, and unfortunately a lot of well-meaning docs will label somebody as having heartburn where in fact they're having angina.
Let's move down, Brad. Let's move down into the stomach a little bit. There's been some questions about inflammation in the stomach from acid reflux, and the question of ulcer and some of the other things happen there or come up from that area. Can you talk a little bit about inflammation in the stomach?
Sure. Inflammation in the stomach, gastritis, can actually have a number of different causes. I think a lot of times it gets labeled simply as a hyperacidic kind of state where the inflammation sort of propagates because of the constant contact irritation, but it can actually arise from a number of different conditions that don't have as much to do with the acid. Oftentimes when we do the endoscopy, we'll go down and basically recognize some redness or some erythema to the stomach, and that's typically when we'll take biopsies. When the pathology comes back, it gives us a lot of clues to the nature of the inflammation, whether it's inflammation that's consistent more with a high acid state or whether there's another condition causing it. So it doesn't have to be just that, but it can be frequently. And that inflammation can then lead to other problems such as ulcers and erosions and whatnot.
Dr. Sanford, Dr. McKee used the word hiatus hernia. What is that?
Oh, hiatal hernia is where you have a weakness in the wall that separates the belly from the chest, and you get actually part of the stomach riding up into the chest. When that happens, the action of breathing, inhaling air, causes a vacuum in that part of the stomach, and it predisposes people to acid just sort of washing up into the food pipe.
Dan, what is gastroparesis?
That's an interesting question. I'm surprised many viewers even know the term, but gastroparesis is a condition where the stomach doesn't contract the way it's supposed to or doesn't contract at all. And so, one of the functions of the stomach is to contract in a coordinated fashion and ultimately propel things downstream and into the small intestine. And in gastroparesis, the stomach is either not contracting at all or not contracting forcefully enough or in a coordinated way. And so food matter builds up and there's delay in emptying of the stomach into the small intestine, which can cause pain and bloating and nausea, especially after eating. The most common predisposing condition to lead to gastroparesis is diabetes. People who've had diabetes for a long time, especially insulin-dependent diabetics who have other complications like neuropathy, oftentimes develop gastroparesis.
Dr. Sanford, what can cause a warm pain or on the left side of the abdomen?
Oh my, any type of inflammation in the descending colon can do that. Diverticulitis can do it, or any type of inflammation in the bowel. If it's in the upper left, you always think about the pancreas, but usually if people have pancreatitis, it won't be a very subtle pain and it'll radiate to the back. So if your lower left belly is kind of gnawing and sore and crampy, think of diverticulitis most commonly.
Brad, this person has been diagnosed with acid reflux, but rarely has heartburn and does not have phlegm in her throat. So is that the right diagnosis?
It can be. You know, it's an interesting thought because we're really not sure what causes the discomfort with acid reflux. The theory is that once the mucosal barrier breaks down, acid can then kind of penetrate deeper because the nerve fibers that sense that pain are actually right below the mucosal lining. So the current thinking is once it breaks down in food and acid and whatnot, the irritants can then penetrate and stimulate those nerves. But not everybody has symptoms. People may present to me for some other reason for an endoscopy. And when we go down, we can see the mucosal damage, biopsy that area, and sort of confirm that diagnosis. Dr. McKee was talking about diabetes patients with neuropathies don't always sense acid reflux symptoms like heartburn. There can be other conditions where they don't necessarily perceive it, or maybe they've had it for so long they just sort of get used to it and don't really complain of heartburn.
There's some discussion in the questions regarding cancer of the esophagus. Now I would assume that that's going to be diagnosed with your scopes. Do you want to maybe you guys talk about that just a little bit, Dan or Brad, either one of you? You see it on the scope. Say a small cancer of the esophagus, what do you do?
Well, if you see something that you're even remotely suspicious of course, the first step would be to obtain a biopsy. And the biopsy is a really quite sensitive test for diagnosing esophageal cancer. The next step would be to stage it. And there are a couple tests you would go to next to locally stage. In other words, once you know that it's esophageal cancer, you would want to get an endoscopic ultrasound, which is basically it's an instrument just like the scopes we use, the upper scopes, but it has an ultrasound probe, and it allows the endoscopist to basically do an internal ultrasound and do the local staging very accurately, determine if there are lymph nodes and depth of penetration in the esophagus, and then if there's evidence of any kind of local spread, then a CAT scan to look for distant spread, and then, that would be the diagnostic workup.
Paul, can the PPIs, the omeprazoles and medicines like that have any long-term effects? They've been used pretty liberally.
Yeah, and they're overall fairly safe. That's why they're over the counter. They're not prescription medications anymore. The concern is that they can mask some more cancerous or malignant things. If people are having difficulty with swallowing, discomfort, and they cover it up with omeprazole, Prilosec, things like that, they might present to one of the gastroenterologists. These guys, after their tumor has already spread and metastasized and is untreatable. So really, when people start having trouble with heartburn, dysphagia, getting full really quickly after taking a few bites, unexplained weight loss, don't just treat yourself with antacid. Seek help.
Well, I was going to say, I think that Paul's got a good point there, and I'd just add that something that has been in the lay press a lot recently are the kind of concerns with proton pump inhibitors and malabsorption of vitamins and minerals, and especially calcium. Maybe it's been a little overstated, but there's some evidence that especially in postmenopausal women who have been on PPIs for a long time, there's some slight increased risk of hip fractures. And I think the PPIs are maybe a little overused. Paul's quite right. They really, as prescription medicines and over-the-counter medicines go, are really quite safe. But at the same time, if there isn't a good reason to take it long term, just like with any medication, you shouldn't. There's also concerns in that when you're suppressing acid in the stomach, you're taking away one of the body's barriers to infection, and so there's an increased risk of certain kinds of infection, and like Clostridium difficile and a few others. So there are some health concerns about ongoing use, maybe not overly serious ones, but concerns nonetheless. And so if there's a good reason to be on a PPI long term, so be it. But like all prescriptions, you should be careful about making sure that the benefits outweigh the risks.
Good points. Dr. Irwin, after eating, why does diarrhea occur? We're starting to mix the upper GI with the lower GI of next week. Just a little bit. Just one question.
Now repeat the question for me one more time.
After eating, why does diarrhea occur?
After eating, why does diarrhea occur?
Or anybody that's got an answer for that one.
Yeah.
Well, I guess the easy, quick, get out of the question answer would be there is such a thing as, it's not really a reflux, but when the stomach becomes distended, there is a bit of increase in colonic motility. So you will stimulate a bowel movement after eating, and it's potential that some folks have what we call rapid transit, where they'll eat and they'll feel the urge to have a bowel movement very quickly. And sort of the common theory behind that is this sort of reflux mechanism or this normal physiology. And I guess it can be a little bit heightened in certain people. After that, there can be any number of reasons why somebody could have diarrhea, and it kind of comes down to the timing of when they ate or didn't eat, and probably get into a whole segment based on just that one problem.
What's H. pylori? You want to talk about that a little bit?
H. pylori is a bacteria, actually. It's rather an interesting one. It was discovered by an Australian physician who won the Nobel Peace Prize when he connected it to peptic ulcer disease. For many years, a lot of people thought he was kind of crazy, but eventually he was borne out to be correct. But the interesting thing about H. pylori is that it's adapted itself to live in a very acidy environment in the stomach. And it possesses certain factors that help break down the normal mucosal barrier in the stomach. And when that happens, people that have H. pylori can develop peptic ulcers. Not everybody with it will get a peptic ulcer, but it is certainly one of the high risk factors for peptic ulcer disease. The other thing that's interesting about H. pylori, not all strains of H. pylori are the same. Some have more or less certain virulence factors that make them class 1 carcinogens. So there's a certain concern that if you have H. pylori and it has certain virulence factors, you're definitely higher risk for gastric cancer. We very frequently will biopsy a stomach of a patient who has gastritis or peptic ulcer disease, looking just for that organism and treat it very aggressively to eradicate it. Otherwise, if they have an ulcer, it may not heal properly even with acid suppression, and potentially it could eventually turn into cancer.
Additional comments, Dan?
I think that's a good explanation, and I think it has been recognized as a carcinogen, and eradication is an appropriate thing to do whenever it's identified. So it's a good point.
What is bile reflux?
Well, we recognize that we worry about acid, and people talk about acid reflux, but the stomach is not just full of acid. It's really, when you reflux, you're refluxing a soup that's made up of lots of things, and frequently bile from the small intestine enters into the stomach, and the contents of the stomach contain frequently partially digested food and acid and bile and digestive enzymes, and when you reflux, it's a mixture of all those things that are coming up, and bile reflux you would rarely, if ever, reflux purely bile, but I think the point is, or maybe the point that the caller is asking about is, you can reflux things other than acid. And so for some people, when you treat acid reflux with an acid suppressant, you may not take care of all their symptoms, because suppressing acid is fine, but there are other things in the stomach too. And by eliminating the acid from the soup, you've just taken out one of the ingredients, and there may be other things like bile that are coming up too. So the physician may have said, well, I think you may have bile reflux, or maybe more appropriate to say you have non-acid reflux, and bile is probably one of the ingredients.
Paul, after the gallbladder has been removed, what is the cause of similar attacks in the future? And we see that.
Yeah, well, typically if your gallbladder is acting up, you'll eat a cheeseburger and get a cramping ache. It can be in the right front side or back, and nausea, vomiting. Don't tolerate fat foods. You take it out, and then afterwards, you think, "Oh, good, I'm done with this." Well, unfortunately, when you eat that cheeseburger, you want that splash of bile to help keep the fatty materials digestible, and you can get cramping or diarrhea after you eat that cheeseburger after your gallbladder's out.
I have pouches on the top of my esophagus. What is the treatment? Either one of you. Unless you want to go after it.
Sacred diverticulum? Or,
I assume that's what they mean.
Well, if it's a Zenker's and it's a large Zenker's and symptomatic where food or other materials are getting caught in it or causing trouble swallowing, surgery is probably the best option for that patient. There are other maybe not so common things that can occur more in the proximal esophagus. We have webs that we'll see periodically. It's interesting, some people are born with ectopic gastric tissue in the proximal esophagus, and that's called an inlet patch. And again, it's somewhat theoretical, but that can also secrete acid, and that can lead to some breakdown of the mucosa and potentially to those webs and rings too. So don't see it very often, but it can be there, and that can create some problems as well. But the Zenker's is probably what you're referring to, and it's a surgical problem.
What causes gallstones, and is there any treatment other than surgery?
Oh.
Well,
I'm fishing on that.
Yeah.
Whoever wants to
air bile.
the cause of gallstones is pretty complicated physiology, but basically the short answer is the bile becomes saturated, and there's to put in simple terms, there's sort of too much cholesterol that can, for the bile to keep in a liquid state, and so it precipitates out, and at least when we're referring to the most common kind of gallstone, and that the cholesterol comes out of the liquid state, and it forms little tiny microcrystals initially, which coalesce and ultimately form stones. And as far as other treatments other than surgery, back in the 80s, folks got excited about looking at using lithotrips, ultrasound shock wave treatments, and also trying to dissolve stones with different chemicals like methyl tert-butyl ether and different medications to try to dissolve stones. And in short, the bottom line is none of those things have panned out. They don't work. And even if they work in the short run, new stones will form, and so surgery is the answer. If you have gallstones and they're causing problems, see your surgeon.
Paul, are there other tests for H. pylori besides a scope down your throat?
Well, there's a lovely test called the urease breath test that you swallow a material and then you exhale it. If there is a nasty little corkscrew-shaped bacteria called Helicobacter eroding your protective layer of your stomach, you will actually be able to assimilate this chemical, and you can measure it as you exhale. It's not as sensitive as an upper endoscopy. The gold standard is still having these guys do an upper endoscopy and biopsy, or CLO test.
What causes stinky spit?
Oh, boy.
Oh, joy. Dental caries, Zenker's diverticulum with foul putrescent material rotting in it. Anything else? I don't know.
No, I mean, holy mackerel, that's tough. There could be a lot of conditions that aren't classically in our realm that could do that. But I think you hit on it. I think about the oral cavity is my first thought.
Poor hygiene, gingivitis, lots of things.
Sure.
Why does our stomach gurgle and make noise?
Speak for yourself.
I am. I'm asking.
Just percolating gas and cheeseburgers and chili and everything.
There is a question here about flatulence.
Oh, no, not again.
That's next week.
Yeah, that's next week. Thank you for redirecting us, yes.
Is there a safe period of time to take Prilosec? We kind of
Well,
danced around that a
yeah,
little
but
bit.
I think in general it's a safe medicine. There's a best time to take it, which is probably 20 minutes or so before breakfast, but I don't think there's one time that's safer than another. It's generally it's pretty safe.
I want to thank our panelists, Dr. Brad Irwin, Dr. Daniel McKee, and Dr. Paul Sanford, and our medical students, Travis Burketsky, Samuel Miller, and Marie Whippler. Please join Dr. Alan Johns for our program next week on lower GI problems, when his panelists will be Dr. Gail Baldwin, Dr. Robert Erickson, and Dr. Ken Ripp. Thanks for watching, and good night.